Hello, everyone. My name is Aisha Langford, and I'm the founder of Funeral Syllabus, where our motto is make a plan, keep the peace, leave a legacy. Today, I have the pleasure of speaking with Angela Novas about hospice care. She is a nurse practitioner by training and currently serves as the Hospice and Palliative Care Consultant for Hospice Foundation of America. The goal of today's podcast is to give a general overview of hospice and to distinguish between hospice care and palliative care. So let's jump right into the questions. So, Ms. Novas, can you tell us a little bit about your professional journey and what motivated you to go into hospice care?
Certainly. Thank you for inviting me. I really enjoy these events and sharing the word and educating people about what we do. So I started out as a nurse practitioner, as a new nurse practitioner, as an attending in a continuum of care facility where we had skilled nursing, rehab, um, and long-term care patients, all in the same building, all with different needs. Um, for the most part, the majority of our patients and residents were very old, very frail, and there was a pattern. We did CPR a lot in the building on patients that were very old, very frail, and very sick, and they were bouncing backwards and forwards from our facility to the emergency room, and of course, back again because there was nothing really that could be done. And everybody was full code, and everybody um, wanted the maximum amount of medical intervention possible. And when I spoke to these people, that was kind of their default setting because they didn't know that there was something that was an alternative out there for them. Most of them were distressed by going out to the hospital so frequently. They never came back as well as they left. The declines were obvious, but they just kept doing it because that was the cycle that they'd fallen into. I didn't have a tremendous amount of education on hospice and palliative care um, in my journey from nurse to nurse practitioner. So started looking into it on my own and started having these conversations. And they were very well received. People didn't know that there was an alternative to dying in the hospital um, and enduring these procedures and taking medications every day that weren't really helping them and weren't adding to their quality of life. And once I started having these conversations, it really did sort of turn around a lot of the people and improve the quality of life for whatever time they had left. Um, so that was when I first started seeing the value in the work, those conversations that they never trained us to have in nursing school started to become easier and easier as I saw how people were willing to engage in them. I think there's always this hesitancy in medical providers to not have those difficult conversations. But sometimes people are just waiting for the medical provider to initiate. They feel like it's the doctor or nurse's responsibility to initiate those conversations and
Okay.
don't bring it up.
Hmm.
But actually, once you get them talking, they really do want to have a plan and they do want to have a say and be heard in how they're cared for.
Okay. And that leads right into my next question. So, for those who've never heard of hospice, what is hospice and what is typically involved once someone goes into hospice?
Hospice is a way of thinking rather than a place. I think a lot of people use the terminology surrounding hospice interchangeably. They'll say palliative care meaning hospice and hospice when they mean palliative, and they think that hospice care is a place like a hospital. It can be, but the majority of hospice care in America is completed in the home. People stay in their own home, wherever that is. Okay, it can be a long-term nursing care, long-term stay home, their apartment, wherever they are, the care goes to them. It's a philosophy rather than a building. And it's a philosophy that embraces the fact that the majority of people want to die in their own home. They don't want to die in a hospital, and they want to be comfortable. They want their symptoms managed. They don't want to be in pain. And so we take resources and services and expertise to them so that in their last months, weeks, days, however much time they have left, they can be surrounded by familiar items, familiar people. They can be comfortable in their own home and know that anything that happens, there is an interdisciplinary team of highly trained professionals who can help them and their family members through that transition.
Okay. And you mentioned an interdisciplinary team. And so, what types of professionals, I know that you're a nurse practitioner, what types of people may be on that team? And in addition to pain management and comfort care, are there other aspects of hospice or the philosophy that people should know about?
Absolutely. The interdisciplinary team is the core of hospice care, and it's somewhat unique to hospice and palliative care at end of life in that it's not just a nurse coming to your home. We also have home health and nursing aides to help with caregiving in the home. Several times a week, nurses will visit, certainly. There'll be a social worker, grief counseling services, chaplaincy services, volunteers. There's a wide variety of volunteer services that people generally offer, and it can be anything from a comforting massage to Reiki therapy, pet therapy, or even music therapy. And again, these people are coming to your home. Even something as simple as having a hairdresser do your hair for you as a volunteer or paint your nails. It's remarkable the impact these volunteers can have on patients' lives. And it also gives the family caregivers a little bit of a break. They too are part of the care team efforts, if you will. So we're not just treating the patient or visiting the patient. The focus is on the patient, of course, but also the family caregivers and others that are supporting them and caring for them around the clock.
Great. And you mentioned that hospice is not a place, it's really a philosophy of care. Maybe this question doesn't make sense, but are there different types of hospice or maybe different settings where people may receive hospice care if for some reason they can't be at home or don't want to be at home?
Well, yeah. I mean, there are several, it's not a different type of hospice, it's just a different setting based on the needs of the patient.
Okay.
Okay. There's four levels of care. There's routine level of care, which is essentially the model where the patient is in the home. The family members or paid hired caregivers are tending to their day-to-day needs with support from the interdisciplinary team. These are generally well-managed patients. Their symptom burden is limited. They may be dying, but they're dying comfortably, and we don't have any concerns that something is going unmanaged. Now, if a patient in the home has a pain crisis. That's most often what people fear is that they'll have a pain crisis in the home. Um, Hospice will go to the home and attempt to manage whatever symptoms they are, and they'll do that aggressively. If necessary, they'll offer what we call continuous care. And that's when they'll actually have an RN in the home for an extended period of time, aggressively attempting to manage those symptoms. If that's not possible for whatever reason, then there's another level of care called general inpatient care, which means that the hospice organization will transport that patient from their home setting to an inpatient facility where they will get sort of a level of care that we tend to call it sort of the hospital of hospice. There are registered nurses there around the clock, there are attendings, there are nurses aid. It really is a setting where we take people whose symptoms we cannot manage in the home for whatever reason. Um, that used to look like hospice house. Okay. But hospice houses are expensive to run and staff. And so there are fewer and fewer hospice houses now. But what hospice organizations are doing to cover that need, to make sure that they can address those needs with their patient population, they're contracting sometimes with hospitals who have a separate hospice wing or ward on their unit that will address those needs, or even a nursing home, a local nursing home, where there are staff there 24/7 who can be really aggressive at symptom management. With general inpatient, we always try to get people back home. That's our objective. When you go general inpatient, the objective is to manage those symptoms, titrate those medications until we can get you back home, because that's where most people want to be. But inevitably, some people do pass and die while they're in general inpatient. And the other level of care is respite care, where you can have your loved one taken to a local nursing home that again is contracting with the hospice agency. And for free, they can spend a period of time in respite care while you take a break or you get your surgery as a caregiver or make doctor's appointments or just have time for yourself. And that's something that they can take advantage of in each of the hospice benefit periods.
Okay. And this sounds wonderful in the sense that people get around the clock care and really comprehensive care, but it also sounds like it can be expensive as well. So, how is hospice typically paid for? So, for example, is that something that insurance covers or people have to pay out of pocket or both? How do people pay for this?
So Medicare covers the hospice benefit 100%,
Okay.
including durable medical equipment. So if you're being cared for in your home and your family's straining their back, taking care of you in your regular bed, let's say, they'll provide the medical equipment that you need, whether it be a hospital bed, Hoyer lift, um, walking frame, wheelchair, any of that durable medical equipment is also covered under the hospice benefit. Um, also, hygiene supplies for incontinence care, those supplies are covered. They may not be as nice as some of the ones you can buy commercially, but they are covered for free. And that's a big deal because those things are expensive to pay privately. So Medicare covers the entire benefit. Um, Private insurance mostly covers. I can't think of one big insurance company that doesn't cover the hospice benefit.
Okay.
Um, there is also if somebody doesn't have insurance, and it happens quite a lot that people don't have insurance but would benefit from hospice care. Hospices generally have a fund which they can provide hospice care free of charge to those who cannot afford it through charity donations. That because we can't quantify how much money any one hospice is collecting, they do what they can, but those funds are not unlimited. And
Okay.
people can also pay. I mean, if somebody doesn't meet the Medicare eligibility um, requirement, but they want hospice care, you can pay to have that. if you
Okay.
have the means and desire to do so. But just to clarify, most people who have hospice care at home, we're supplementing the caregiving in the home that already exists. While
Right.
hospice has availability by phone to speak with a nurse, and in an emergency, a nurse will come out to assist and assess. Um, in reality, what hospice looks like is an hour a week with a nurse, perhaps, um, an hour or two, 3 times a week with a nursing aide, and other visits from chaplaincy, social worker, or volunteers on an as needed basis. Um,
Okay.
the 24/7 inpatient care is not something that people can elect. And
Okay.
again, that you have to meet um, quite strict parameters for symptom control to be admitted as a general inpatient. Um, but if you meet those parameters, it's there and you will get that 24-hour, 7 day a week intensive care if that's the only way we can manage those symptoms and make you comfortable.
Okay. And my next question, you mentioned earlier that sometimes people use hospice and palliative care interchangeably, but they're different. So can you just explain the difference between hospice and palliative care?
Okay, so it's best explained with an example. So
Okay.
if you had somebody with pancreatic cancer, which is very aggressive, um, and they also have an anticipated life expectancy of 6 months or less, if that cancer runs its course without aggressive intervention, you would be eligible for hospice care so long as you either were not responding to treatment and no further treatment was being offered, or you said, look, I've been through the treatments, I've had the surgery, I'm miserable, it isn't working, I want hospice care. That avenue is available to you. But if you were to say, look, I don't care what the doctors say, I want another round of chemotherapy. I want to have another surgery. I want to have as aggressive a treatment as my doctors will offer me for as long as they will offer it. But I also want the support of symptom management and an interdisciplinary team. You can adopt palliative care so that you can continue to receive some care from an interdisciplinary team and aggressive symptom management while still pursuing curative therapies. It doesn't look quite the same. The palliative care is still not offered as much as we would like it to be because of the availability of palliative care providers in some more rural areas. But it is another option, and it does allow some people to experience that support for themselves and their family members during what may be a transition, so that if you transition from palliative to hospice, you are with a team that's familiar with you, and it just makes that feel less ominous than being admitted to hospice.
Right.
So yeah, so the two are like hospice care is for when no further treatment is working or you're declining aggressive therapy, and palliative, it has to do with basically the payment structure of the
Okay.
two services.
Okay. And my last question, as you know, talking about end of life issues like hospice and palliative care makes people sad, especially with hospice care, because you know essentially what's coming. So, what resources are available to help families and friends really deal with the grieving process, I guess, before their loved one leaves and then after they leave?
That's what both palliative and hospice care offer, because, you really start to grieve for a person the moment they receive that life-threatening diagnosis,
Right.
right? And so that's why we have social workers and grief counselors who will begin working with you from day one. Grief counseling doesn't start after the loved one has died, although hospice does provide grief support for 13 months for the family members after the loved one have died. But many hospice patients and their family are grieving at the time of admission, either from palliative care or hospice, because they know this is coming for patients and families who have Alzheimer's and other chronic conditions where you're losing that person before they die,
Right.
right? Because of the cognitive changes and personality changes, those people need that grief support right away in it dealing with that anticipatory grief as well as the grief that they feel post-death.
Okay.
And
Wow.
a lot of people, I think that, well, I've been grieving for this person for a long time. The grief after death won't be as acute, but that's not supported by evidence.
Right, right. And when you say these services are really provided throughout, so does that look like, I guess, clergy members, or if someone's not religious, what other types of, I guess, social workers, or what other types of things can be done, I guess, depending on people's preferences and what kind of spiritual support or not they may want?
Yeah, hospice chaplains are usually non-denominational.
Oh, okay.
So, if you want to see a priest, the hospice and palliative care will work with you to find somebody of any specific denomination that you would like. But we're not there to proselytize to people at a time when they're vulnerable. If you don't want to speak with a chaplain at all, that's fine. But these services are there, and the chaplains are non-denominational. We don't ask anything from anybody. We're not trying to convert anybody. We're certainly not asking people to repent. But sometimes when you do have a life-threatening condition, then you do, of course, you're confronted with your own mortality. And this does raise issues with people and their relatives. And whether it's a social worker or whether it's a chaplain or whether we're able to link you to a local group of like-minded people, whether it's spiritual or religious or anything else, we're there to make sure that happens for you and facilitate that.
Okay. That's wonderful. Those were my main questions as our first introduction. Is there anything else you'd like to add that I didn't ask?
I think we've covered the basics.
Okay, great.
And I think, we do a lot of work at HFA to make sure people hopefully have these conversations before the conversation is needed. We're very passionate about that. Um, but our website is actually wonderful. So if any of your viewers have any other questions or want more information, they can certainly reach out to us at hospicefoundation.org. Um, we have a wonderful service that we offer free, where we can offer advice about hospice care or even grief. We have experts for both. And you can ask an expert, and that's a free service that we offer. We spend about 20 hours a week responding to questions from the general public
Wow.
about how to access grief resources, palliative and hospice care, and eligibility, and just making sure that people connect with others who can help them.
Okay. Thank you so much for spending your time and expertise with us today.